All right, I will call to order the March 16th, 2026 Belmont City Council Workshop meeting. Don't believe there are any changes to the agenda as is presented, so I will entertain a motion to set the agenda.
So moved.
Right.
Second.
Mark, seconded by Jason, all in favor?
Aye.
Any opposed? All right, the agenda is set. Moving to item B1, I believe we have Hannah that will be introducing everyone. And again, just so everyone knows, the microphone is a little low, so if you don't mind, getting nice and close.
Thank you, Mayor and Council. Can you hear me okay?
Mm-hmm.
Okay, my portion is going to be brief before I bring Donna Nixon with Hub International up here. I want to give a brief history, background, and a little bit of a refresh in the timeline that brings us to where we are today and why we're having this discussion. All right, so back in late February of 2025, the North Carolina League of Municipalities, they shut down their health insurance trust, effectively pulling us out of their health pool as of July 1st of 2025. Because of that, it put us into a compressed timeline. We had to rush to secure a broker, get quotes to secure health coverage for all of our employees in time for open enrollment and budget. We looked at approximately 4 different brokerage firms, and we compared them based on municipal insurance, excuse me, service capabilities and implementation support, and ability to meet the compressed timeline that we were in, as well as cost competitiveness. We compared it down to about 2, and of that 2, we did partner with Hub International. We were impressed with their service model, their employee education, communication, and open enrollment support that they provided. They have really good HR tools and compliance resources that they include as well. They have specialized knowledge in alternative funding strategies and deep public sector and municipal government experience. And of the 2 that we were considering, they were the most cost-effective option among the top finalists. Once partnering with Hub, we sourced quotes, and as you can see, due to our poor claims year, we were declined quotes from all major full coverage carriers except for United Healthcare. So we were kind of backed into a corner there. We had to go with United Healthcare.
Hannah, can you give some perspective on when you say poor claims history? Was that like a one-time spike for the last year, or was it more of a multi-year?
So there's a 24-month look back for claims history, and I don't know if you're able to see. You're going to go into that.
Okay,
Yeah.
sorry.
So yeah, we were kind of backed into a corner, and United Healthcare was our only option, so that rates didn't spike astronomically for our employees who have dependents on their coverage. This is a brief overview of what our rates are currently under United Healthcare from the perspective of an employee. This is cost per pay period. The city does pay 100% premiums for employee-only coverage. We do not contribute to dependent premiums. Employees have to absorb those costs. These are the costs for employee, children, spouse, and family per pay period, as well as annually. The city has approximately 190 employees on our health plan. Of that 190, 148 have elected employee-only coverage, paying 0 in premiums. 33 have elected employee child, 7 employee spouse, and only 2 out of the 190 have elected family coverage. So of those 190 employees, only approximately 22% have elected dependents at all to be placed on their health plans. This is a good indicator that our plan design discourages dependent coverage. In current family enrollments, health premiums consume 50 to 30% of annual gross wages for those 2 employees that are carrying family coverage. The city has approximately 18 employees earning under $43,000, including 7 who could potentially add dependents but would likely face similar affordability challenges. And this doesn't exclude employees above that $43,000 threshold who also would face affordability challenges. It's a reoccurring thing that pops up in our exit interviews and in general, and especially during open enrollment season. So currently, while we went with the decision to go with United Healthcare, we do understand there's been employee dissatisfaction. So we've been working with Hub to evaluate alternative strategies to improve both the employee experience and long-term cost stability for the city. One option being considered for is transitioning to self-funded. hopefully to provide greater cost transparency, more control over our plan design, which would be very helpful, and potential long-term savings. So with that, I'm going to hand it over to Ms. Donna Nixon with Hub International.
Thank you.
Good evening. Thank you, Hannah. Thank you, City Council. It's a pleasure to be here with you tonight. So, my name is Donna Nixon, and I serve as Senior Vice President with Hub International, and my primary role is to serve as our employee benefits strategist to really help all of our groups kind of think through decisions such as this, make sure that we're bringing all of the creative options to the table for consideration and how to structure a benefit program that's going to help you attract and retain your employees. So I'd like to start off by sharing a little bit about, as Hannah mentioned, you know, the experience as to where you have been and kind of where you are currently today. And so this chart right here shows 29 months worth of claims history. The red line that you see around the bottom is the 85% carrier target. And so regardless of where you obtain your health insurance, they are going to want your claims to run at a loss ratio of 85% or lower. So this chart kind of shows 29 months worth of data, and you can see here the numbers represent what that loss ratio is. And loss ratio is simply just taking your claims divided by your premiums that you're paying for that coverage. Everything above that red line means that your healthcare provider paid more out in claims than it received in premiums. Everything under that line means that the city of Belmont paid more in premiums than what were incurred in claims. And so you can see there's been some pretty rocky months as far as what that claims history looks like. You know, loss ratios as high as 358%, with some real spiked claims there. The majority of those large spikes really are attributed to high-cost claimants, so things, you know, such as cancer or high-cost specialty medications, and we'll show a little bit about those here a little bit further. But as Hannah mentioned, you know, when the League of Municipalities closed their funding pool, it did leave, you know, the city of Belmont and many others in kind of a bind because the claims history wasn't favorable, and yet you still had to go out to the market and find health insurance for your employees. One thing I just want to make sure people understand is, you know, the League of Municipalities really got a lot of leeway in how they structured their program. They were established for the betterment of their membership, the cities. And so they were really trying very hard to keep their rates as low as possible. They did operate like a fully insured program from your perspective, meaning you just paid a flat premium each month and they paid the claims. They took all of the risk for all of the municipalities. Where it ran into trouble is obviously once you start to have claims that are exceeding that premium amount, you know, there's no choice but all of that to be compacted, and then all of a sudden there's not enough premium there to continue to offer that program. However, the timing created a huge burden and challenge for municipalities across the state because there really wasn't a lot of time to really kind of dig in and say, you know, what can we do about this today? And then, you know, even though they did provide some claims information, the carrier market, the traditional insurance carrier market, really just didn't have an appetite for that risk. So as Hannah mentioned, United Healthcare really was the only one that gave a benefit package. They did so at a pretty favorable rate, in our opinion, and so we have been completely transparent with Mr. Braswell and your finance officer that, you know, we are worried because the pattern has continued as far as claims experience, what that renewal is going to look like from United Healthcare. And so our actuary and underwriters are projecting a renewal increase between 25 and 50% for this next July to June time period. So with that, we wanted to make sure we were really talking through alternate funding mechanisms that the city may want to consider as we kind of move forward outside of the fully insured market. And so I'd like to dive in a little bit and share with you, you know, how you are funded today with fully insured and what challenges that creates. So the fully insured model is really fundamentally designed for the insurance carrier, not necessarily for the employer. Under the traditional insurance, there's really 4 types of things that are happening that, most group plans really aren't being made aware of. And, the first one is those hidden margins. So the carriers do build in profit margins right into their premium. You don't really ever see what the claims cost. It's a pretty limited amount of data that you receive. When the claims are running low, the carrier keeps all of that profit, and you don't really know, what that really looks like. The second thing is really that limited claims visibility. So the data, your claims data, actually belongs to the carrier. It does not belong to the city of Belmont. So they only provide very limited data, which makes it, nearly impossible to target those cost drivers because you don't really know what they are except for very general claims information. So it makes it very difficult to make informed plan decisions. Next is really, the renewal roulette, as we call it. Every renewal is really dictated by the carrier's pricing model and the market conditions. One bad claims year can really trigger double-digit increases, and there's really no recourse or transparency, especially if there's no other competition in the market that's available to provide a quote. And then lastly, the pharmacy benefit management services kind of creates a black box. All of your pharmacy costs are really kind of hidden into your premiums, and that pharmacy benefit manager profits from spread pricing. You don't really see what the drugs cost, what the carrier's really paying the pharmacy for those medications, and all of the manufacturer rebates are going back to the pharmacy benefit manager, the carrier, and not to the city of Belmont. So that's kind of exactly the arrangement that y'all have today, fully insured arrangement with United Healthcare.
Donna,
Yes.
quick question. With regard to renewal pricing, is it purely a rear view facing perspective on the renewal rates, or is there any consideration given to, for instance, employee attrition? If for instance, some of those participants that had triggered some of the spike in claims, if they're no longer a participant in the plan, does that have any factor in renewal rates, or even who might wish to bid on our plan?
So that's a great question. So most of it is really attributed to historical information, right? Because the carrier's saying, we paid out X, we didn't receive enough, right? So we want to recoup that money. However, we do work very closely with HR, kind of trying to monitor, hey, we can see that there's these 4 high-cost claimants. The problem is there's no data transparency, so I don't know who they are. And so we're like, do you happen to know who they are? Sometimes in a group of your size, right, because somebody's out on disability coverage or something. But like if it's a spouse or dependent, we may not know who those high-cost claimants are to do some of that fact-checking as far as, are they still on the plan? Are they off the plan?
Regulation?
It is.
Really?
It is.
Interesting.
And again, they own the data. You don't own your data.
Never realized.
So, so when we are made aware of, perhaps, this person came off the claim, and they would have to exhaust their COBRA eligibility window for us to be able to then negotiate. We don't want this claimant to be considered in the renewal. It's really hard to try to do those negotiations, though, on a fully insured basis, again, because they're looking in the rear view, and they want to, regardless if the person's going to be here or not, they want to recoup the money that's kind of been paid out.
Okay.
But excellent question.
Thank you.
So when we think about kind of the negatives or the challenges that exist in fully insured, we really want to think through what's that alternative. And self-funding is really the alternative that we think most employers that really want to try to retain the best odds of winning in the insurance game really are self-funded. So how that works is instead of paying a fixed premium every month, you would simply fund a claims account and you would pay as you go. So right now, if you have 190 people on the plan, you're paying that premium for 190 people. And you have no idea whether claims are being incurred or not. In a self-funded arrangement, you're still going to set your budget rates. You're still going to collect employee contributions. However, you're going to hold that money in an account, and when claims are incurred, they will draw money out of that account to pay for those claims.
Do we need to seed the account at the beginning? So like, so there's money to pay claims if somebody makes a claim like in the first month?
So naturally, there is a lag when you make any type of carrier transition, because claims have to, even if they're incurred July 1st, right? They don't get billed by the provider usually until closer to the end of the month.
Right.
You're still collecting those contributions and still have funded at your premium rates. So you're going to have money in that account, say the first paycheck of the month, biweekly, to have that money there. Obviously, it's a great idea if you can fund in advance so that, say, you get that high cost claimant in month one, right? You want to make sure that there's money there. I'm going to talk a little bit about how we're going to protect the plan as well to make sure that you do have not as much volatility as what it sounds like in a self-funded arrangement, to offer that protection for the city.
Donna, real quick, just a point of clarification for me. So if it's pay only as you go, are the insured through the city, our employees, are they treated as cash pay for purposes of the claim amount that comes back?
No, they are not.
Okay.
So even though you are paying as you go, we do structure the plan with a third-party administrator that pays the claims. And more importantly, we also provide a provider network for that coverage. So just like today, they have employee ID cards that say United Healthcare on them. We would go ahead and build a plan that has a provider network, maybe MedCost, who the city has used in the past as a provider network, maybe Aetna, another big national network. They also have the state health plan here in North Carolina, so very, very robust network. What that means is when they have that network, you all would benefit from those provider contracts that exist inside that network to get that discounted pricing. And employees would still render services just like today. They'd show their ID card. If it was an office visit, they'd pay their copay. The city would just then be billed through the third-party administrator, kind of on an aggregate basis for those months' claims.
Okay, thank you.
Does that answer your question?
It does, thank you.
Great. So with the self-funding model, you pay as you go. You also receive full transparency. So to your question earlier, well, what are the high-cost claimants? Like what's driving our costs? Today we have very limited insight. When you are self-funded, we would have full insight into all claims that are paid. Obviously, we do follow HIPAA regulations, right? You would designate who here at the city actually has HIPAA authorization to actually see that level of detail. But what that does is that allows us a couple of things. One, it allows us to really try to provide some risk mitigation for claims that are ongoing. And it also allows us to really customize plan designs knowing the types of services that are being rendered. And then, as I mentioned, most self-funded employers really do feel like they are in the best position to win in this arrangement. However, it can feel scary. There was questions about, well, do we have to fund in advance? What if we get a large peak of claims? We also want to make sure that you have stop loss being built into this program alongside your TPA, your provider network, and your pharmacy benefits to offer protection. And I'll dive into kind of how the stop loss works here in a moment. So self-funding really lets you kind of choose that best-in-class vendor. Third-party administrator. Today, United Healthcare basically is doing that work. They're offering ID cards. They're processing claims. They're taking on the risk for you all today. City of Belmont would actually have that covered through stop-loss insurance in this model. So stop-loss insurance can be structured in many different ways. The most advantageous for groups of your size is to go through a captive to purchase stop-loss insurance. That captive uses excessive buying power to basically get best-in-class stop-loss insurance, and most importantly, they get contract terms that are going to provide the city with protection, meaning they're going to cap the most that you're going to pay. And they do that in two different ways. They're going to cap the most that you pay per claimant. So that high cost claimant that maybe has, $900,000 in cancer expenses, your exposure for that one claimant would be capped at maybe $75,000 as an example. They're also going to cap your exposure for an aggregate of everybody in the plan. That's like just incurring regular doctor's visits, emergency rooms, co-pays at the pharmacy. They're also going to provide you with aggregate protection so that you know in one plan year, this is the very most that you're going to be able to spend if you add up all 190 employees and their dependents on the plan and their incurring claims. The other thing that we feel is really important for groups your size is to make sure that that stop loss protection offers some guarantees as far as what do my rates look like next year. Because the same philosophy that we talked about in the fully insured arrangement as far as, well, they're going to use that rear view thinking of, oh, I paid out more than I'm receiving. We want to make sure that there are some protections in place to cap that exposure for the city at renewal. And so rate guarantees are going to be something that we're going to make sure that the captive has in place and can negotiate. And I'll share a little bit more about those percentages here in a moment. We also want to make sure that you're using a transparent pharmacy benefit manager. So today, United Healthcare uses Optum Rx as the pharmacy benefit manager. So you have on your ID card, it says Optum on there somewhere. That's who's actually really sourcing the medication, setting the prices for the pharmacies, and managing the pharmacy formulary. They're also the ones that are receiving all of the rebates instead of passing those on to City of Belmont. So we think it's really important to choose a pass-through pharmacy benefit manager to really manage your plan to the lowest cost of transparent pricing. And so you paid them an admin fee, they're sourcing the drugs and building in programs to make sure that you are paying the lowest cost for those drugs. Still works the same from an employee level. They're going to a pharmacy with an ID card, paying their copay at time of service. We talked a little bit about network access, making sure that you have the right network of providers available to make sure that there's full access for all of your employees and that the city can benefit from the provider discounts. Care management is another piece that we want to make sure gets built into the program from the start. Again, making sure that, when we get to start looking at what those claims are, do we have the appropriate health management systems in place to help the employees and the patients actually manage their care so that they are getting healthier quicker, managing that spend and getting the very best care that they can for that condition. And then lastly, really making sure that you have the claims reporting that can help you guide plan design, cost forecasting, and control, and most importantly, budgeting and predictability. So when you get to see under the hood, it really does allow us to do underwriting in advance so that we can provide you on a month-to-month basis a projection as to where do we think your costs are going to be, in that next plan year. So, a lot of employers like that from a funding standpoint that, there's a little bit more transparency earlier in the process than exists today. So talked about pharmacy a little bit, that pass-through PBM model and why that matters. Right now, you all are spending about 37% of your total claims on pharmacy. Your traditional PBM, is receiving the rebates on your behalf. You're not really sure what you're paying, what part of your premium is paying for what drugs. We know that with a pass-through PBM, we can have that structured so that you pay the very lowest cost, those rebates come back, and formulary decisions are really based on clinical and financial data that you own, rather than being predicated to you through the carrier. And then patient assistance and coupon programs are maximized. So you all, I'm sure, have seen some TV with some RX commercials. You probably know some of the jingles. Because they're on all the time. Those commercials are there. Basically, those are the highest cost drugs that are available today to treat conditions. Now, don't get me wrong, in a lot of cases, they're life-saving drugs and very much needed. What you don't know is that the carriers are receiving what's called rebates to put those drugs on their formulary lists, to basically say, we want to encourage our membership to use these medications, and in return, you'll send us this rebate. And there are other medications out there that do the exact same things, but maybe don't have the same level of rebate. The carrier decides not to put that lower cost drug on their list because they're not going to receive that financial rebate on the backside.
Otherwise known as a kickback. Yeah.
So we want to structure programs that the manufacturers do offer financial support. So you've probably heard that at the very last minute of the thing. If you have commercial insurance, let us know, and we'll see if you can qualify for patient assistance. Well, the patient assistance part is a really good part of the program. That if that person really needs that drug, we don't want to prevent the person from getting that drug. We also don't want them to have to pay the cost, and really we want the plan to be able to pay the lowest cost for that medication. And so having a program where that patient assistance model is more of the go-to and the standard is really important, not only for the city to make sure they're getting the best cost, but for the patient that needs that medication at sometimes free or, you know, a $5 copay. It makes sure that they are adherent to taking that medication and, you know, hopefully treating that condition the best that they can. In that scenario, that rebate still exists from the manufacturer, but instead of it going to the carrier, it would come back to the city of Belmont. So it's really a win-win in that scenario. So you can see here, you know, I mentioned the pharmacy spend was about 37% of your total claim cost just in this plan year. So just from July through November of 25. And here's kind of your leading medications and the costs of those medications in those 5 months period. Today, every single one of those on this list is generating rebates that are going back to the carrier. And in most cases, we're not really sure, did your employees actually get offered patient assistance to get any of these medications? You know, that's just not a go-to for the care. So, you know, pharmacy is a really big driver. We know that for employers that make this switch, going from a fully insured, and it doesn't matter which one you are, if you're with Blue Cross, Aetna, Cigna, United, if you move from that traditional model in a fully insured arrangement and you move to a pass-through PBM, we are going to see 20 to 40% reduction in your pharmacy spend. That's, you know, every case that we've moved, we see it. And the great thing about pharmacy is that you realize those savings right away because somebody's taking that medication every single month, right? So as that cost is going down, it's not something that you have to wait a year for to say, oh, did we save money? That cost starts to go down right away. So I talked about making sure that you're getting the stop-loss protections that you need. And what we've talked about with the city is really the Pareto Health captive model. Talked about the fact that you choose your plan design and your TPA. So for most cases, when we transition from fully insured, we're going to recommend that the city keeps the exact same plan design. Plan design means pharmacy benefit copays, right? Prescription drug specialty copays, making sure your primary care and your specialist copays are the same, your coinsurance is the same. That's what we mean by plan design. It's just easier for a transition to kind of mirror what's in place today with that new TPA. We're going to help you establish how to fund that claims account, both through the employer contribution and the employee contribution. Again, in any of those months where there's low claims, that money still sits here in the bank account. And then really where Pareto Captive comes is purchasing that stop-loss protection, making sure that we're getting the very best rates for both the individual protection and then the aggregate. And you then become a captive equity owner. So in this captive arrangement, you do have a capital contribution that you provide for the first 2 years. It does sit on your balance sheet as an asset, and it is earning interest and will be returned to you upon exit, and you do receive reporting as to what that looks like.
What exactly is Pareto? I've seen that referred to in the presentation, but I haven't. Like, what is that?
Yep,
Is
so
it
Pareto Health is the name of the captive that we're recommending
Okay.
for
So it's a
consideration.
company?
So it's the company name, Pareto
Okay.
Health. Yep.
All right.
So Pareto Health is actually the largest captive in the nation. I'll have a slide here in just a minute that gives some of their statistics. Wanted to show a little bit more about kind of why we recommend Pareto in a lot of our cases. The pass-through PBM model is in place for them. Again, we see savings between 20 and 40%. They also have integrated cost management. So that was one of the pillars that we said, you know, it makes important sense to put that in place. Basically, they are providing different types of services to help patients really navigate through that health journey. You know, cancer care assistance, where maybe a cancer nurse is helping every cancer patient figure out, you know, was the cancer staged appropriately? Are they receiving care at the most beneficial place? What questions and concerns do they have? Maybe it's something as Valence Health is built in, helping employees find the very best places to go for MRIs, CT scans, or any non-emergency surgeries. Getting those done at the lowest cost, and for reward, they basically get those services for free instead of having those go to deductible and coinsurance.
Do we have anything like that in our current program?
United Healthcare says you can go on their website and use their tool to try to find the very best highly rated providers. You don't really get anything too much as far as cost transparency goes, and there's certainly nothing that's going to incentivize the employees to make good decisions.
Okay.
Can you tell me, and I may have missed this completely, what does PEPM mean?
Per employee per month.
Thank you.
So we use that jargon and we use that metric to you know, show value, because population's always changing, right? So one month you might have 190 people, next month you might have 92, next month you might have 187. So most of the time when we do any type of health forecasting, we're going to use a PEPM just to normalize that value.
Thank you.
Great question. So Pareto Health is the largest captive. They have 3,500 plus employer groups. So, and that comprises about 1.2 million covered lives. So between those 3,500 employer groups, there's about 1.2 million people insured under that plan. Under management, they have $6.8 billion under stop-loss management. So if they were a standalone stop-loss carrier, they'd be the third largest stop-loss carrier in the country. So they have tremendous buying power when it comes to securing that stop-loss. And they have a 96% retention rate as far as the groups that are in the captive, and then they renew year after year. I talked about making sure that the city of Belmont is protected and making sure that the contract language in that stop loss is going to offer that protection. And so one of the provisions that they standardly offer is called a no new laser contract provision. I gave the example earlier of a cancer patient with a $900,000 claim. And I also said that we make sure that we have rate relief protection in your program. We feel like you need to have both of those pieces working side by side, the no new laser and the rate protection. So if you have that $900,000 cancer patient and then you sit at renewal, Pareto Health could do the same thing like United Healthcare and be like, oh, you need a 50, 60, 70, 80% rate increase, right? And we said, well, we want that capped. So they cap that at 30%. Now your stop loss premium is only about 30% of what your overall spend is. So that's really about a 9% increase to the total plan. A 9% increase to the total plan compared to today. We're thinking we're going to be looking at a 50% increase with United. However, the rate cap isn't enough if they could say, well, you know what, you have that claimant that has a $900,000 cancer claim. Instead of offering that protection at $75,000, like I said earlier, for that one person, we're going to laser that person out of that stop-loss arrangement, and we're going to make the city of Belmont responsible for $500,000 for that one person. That wouldn't be right. So we make sure that those two provisions work hand in hand, that once you're in the plan, you cannot have any new lasers in perpetuity. They cannot zero out any one claimant, and they cannot increase the stop-loss by more than 30%. It is the strongest stop-loss contract in the market, and it is exclusive to just Pareto Health members. that really does provide that volatility protection that, you know, self-funded groups that are kind of out there on their own, you know, may experience.
Do they have, sorry,
Yep.
do they have the ability, because I know you said on an individual basis they can't laser out people, but like could they come in and say, okay, your individual stop loss is 50,000, we're going to raise it to 75,000 next year?
So you would receive a renewal at that same spec level. We are going to model for you what it looks like if you go up or down. So you might decide, you know what, we want to lower it down to 50. You're going to pay more for that stop loss. Or we might say, you know what, based on your claims history, maybe you should increase that, take on more of the risk, and maybe you should put that at 100. Then your stop loss insurance renewal is going to go down because you're taking on more risk, they're taking less.
Like your deductible.
But you're not going to be forced to change
Okay.
that
Yeah,
individual
that's what
spec
I was
level.
Getting
Yep.
at was whether
Yep.
they could come in at renewal and say, well, you have to increase.
Right. Where they are going to look is that aggregate coverage, right? So we talked about each individual person would have a cap. Then they're going to really set kind of, hey, as a group as a whole, what do we think that you're going to experience? That's called aggregate protection. They're going to really underwrite to the number that they expect you to have. Because insurance really is to provide protection for those known risks. If they know the risk is there, they're going to underwrite to that risk. So the aggregate protection is really the number that, you know, may fluctuate
Okay,
based on your claims.
okay.
And so for groups who have moved into the Pareto captive, you know, we're kind of showing you their average savings versus a fully insured contract. So in year one, you know, most groups are seeing about a 7.5% decrease on spend. Year two, about 13.2, and by year three, about a 16.5% savings from their renewal projection the last year that they were fully insured.
Oh, hey, okay, hang on.
Yep.
So from the savings from the projected new rate that we're leaving,
Yes.
so we're looking at what, a 50% increase roughly? So we would have a 7% savings from the 50%
That's
increase
correct.
number. Okay.
So just so I understand, like how, and again, insurance is something that's always like a gray area for me, but how are we assuring ourselves that we are going to get a 50% increase from our existing? Has that already been
We're
committed?
not going to assume. We're going to wait until we have those numbers. So today we're not going to ask you to approve this. We're basically just kind of showing this as proof of concept, and we're running both scenarios to really evaluate and help the city decide, you know, what's it going to look like. So we're not making this recommendation today. We're just saying, hey, this is an alternative that we think you should consider. We're going to wait and see what the real numbers are. So we're going to kind of show some illustrative numbers here, right? And that's all they are. They're illustrations because we don't have your renewal yet with United Healthcare. Because again, insurance is priced based on what we know. So anytime you move carriers or anytime you move to either fully insured to fully insured or fully insured to self-funded, underwriters aren't going to release their final numbers to you until they know what that renewal is, right? Because United Healthcare really has the upper hand. They know what your claims are. Whatever they say your renewal is means that they know something that all of us in this room don't know, right? That there are claims that are predicated on what those rates are going to look like. So underwriters are basically going to use those projections in their models to set those new rates.
Okay.
So, but we can get pretty close with some projections, and that's what this illustration here is really a 12-month financial summary from Pareto Health as to, you know, where they think that you're going to be. So they have modeled this assuming that you're going to get, you know, a reference premium of a $2 million. So today you're paying about 1.5, right? They're looking that you're probably going to go up to about $2 million with your renewal. At the time that they did this projection, you all had 186 enrolled employees. And so it breaks down the different components that we talked about that are necessary when you move to self-funded. So, you know, you can see on the left those components, you know, your fixed cost, your benefit administration cost, your stop loss premium, those are your fixed costs, right? You're going to get billed a per employee per month for those costs every single month. to pay your claims, to give you ID cards, to give you access to your provider network. For our services, your stop loss premium, everything's going to kind of be built in there in that benefit administration. That third line is really your claims. And they've kind of modeled for you 3 different scenarios. So you can see a great, kind of a typical and expected, and then a maximum or worst case. So, we're going to really kind of be very conservative. We're going to look at really that expected, or in most cases, that worst case. When we move a group for that first year from fully insured to self-funded, we're going to recommend that the budget be set at worst case scenario. So to your question, how do we have to seed that money in advance? How much of a fund needs to be there? If you budget to the maximum, you know that you're not going to run out of money before the end of that year because you've budgeted to that cap, that aggregate cap. So the worst thing that's going to happen is you're not going to meet that cap, and all that money is going to still be sitting here in City of Belmont's claim fund. And so you can see here we've kind of modeled out for you, what that total cost looks like in that line in the blue under the typical expected or the maximum. So, 2.3 as the maximum claims cost for the City of Belmont. So kind of looking at the 3 boxes here on this page, if you look at the renewal scenario versus Pareto kind of at a glance, if United comes in with a 50% renewal with the membership that you all have today, that's going to be about close to $2.3 million. You can see from the previous page, the expected with Pareto is about 1.8, but the maximum is also 2.3. So again, our recommendation always that first year is to fund to the maximum. So if United's renewal comes in at 50%, you're going to pay $2.3 million next year. If you fund to the maximum with Pareto, on this illustrative proposal, you're going to pay $2.3 million this year. However, what you're going to gain is tremendous under the Pareto model for both the city and for the employees in having that flexibility, that control, and the transparency that's really required to bring your plan to that next level.
And if we don't spend it, it stays in the account.
That's correct. Yes, the 2.3 that you spend with United, it's gone.
Spent.
It doesn't matter if your claims get better, it doesn't matter if they only spent half of it, you've paid that money for that year. The other thing that happens with fully insured, when you have those great years, they come back and they say, oh, you know what, you're great, here's your 5% increase. The next year, oh, here's another 5% increase because of medical trend, right? You've probably heard that medical trend. Oh, costs keep going up. No matter what, even though you're running great, we got to still keep up with medical trend. They very rarely come back to maybe flat. That might be a very exceptional year where they say, well, we'll hold your rates. But very, very few times do they say, you know what, you all did great. We're going to decrease your rates. When you're in a self-funded arrangement, your rates reset every single year. So even if you have the worst year possible and you spend that full 2.3, you're going to reset again at 0 the very next year. And what are you going to spend that next year, right? You're still going to fund at the same amount, but that year your claims run better. That money's sitting there in your account. You don't have to pay that excess amount that next year and over and over and over again.
When these projections were done, I assume you were taking into consideration our past 29-month window, that spike of claims, that was assumed that would replicate again?
Well, so we know in a 5-year period, you're going to have really one great year, you're going to have one really horrendous year, and you're going to have 3 average years. The problem is in that time, we don't really know, is this year even worse than that year? Or was this your great year? We don't know because you don't really get any visibility into what those claims look like. So that's why we say, if you fund to the maximum, you're going to be safe. You know that you're not going to experience that really terrible year and not have the money to fund for it. But they do model based off of that, right? They don't have as much data as they would like to be able to pinpoint exactly like, oh, you know what, this was the stage of the cancer. We think they're just about wrapped up. They're getting better, right? We can take feedback if we know who those claimants are and bring that to the case. The other thing that we can do when you are self-funded and we do have access to that data, Hub has their own technology backed by clinicians. And so when you are self-funded, we will receive direct claim files into our claims integrity system that will allow our clinicians to basically see all the claims and help project with our underwriters to figure out, like, hey, is that really at the end of this claim, or is it at the beginning, or is it in the middle? And they will help us negotiate that stop loss with that information, so that even though you maybe had a horrendous year, if we know we can project forward 12, 18 months as to what we expect your claims to be, that's going to put you in the best position in us to be able to negotiate the very best terms for you,
Okay.
not just based off of what happened in the past, but more importantly, what we expect is going to happen in the future.
And that's why the savings increases as you go.
That's
through the
right.
years, okay.
Really
And because-
data-driven
yeah.
decisions.
And the patients are actually going through these case management types of programs, right? Like, you know, the cancer care, or, you know, getting their MRIs at the lowest cost providers, right? So I always tell people, we can't do this for you. You can't do it for your employees, right? So we're talking a lot about the financials here tonight. The other piece is, right, this requires a lot of communication and education to your employees as well. They need to understand that, you know what, we're providing the very best benefits to you, but we need your help. We need you to be good stewards of the plan. And we need your help in making good decisions. And we're going to be right alongside here, making sure we're making it as easy as possible for you. But they do have ownership into the plan as much as you all do when you set that budget.
What does our historical renewal pricing look like over the last, say, 2 or 3 years in terms of increases? I know we haven't had any reductions, I'm pretty sure, right?
Mm-hmm. I don't know what your renewals were like when you were still with the league.
Right, but I mean, are we? But like, the increases that we've had have been, they've been on the order of like 15, 20, 30%. I think we had a 30% renewal within the last year or two, didn't we?
So this last renewal, I think it was about a 22% increase from the league.
Sounds, yeah.
Yeah. You know, the years prior, again, being part of that program, you know, the biggest problem that we had when we went out to market is that because the league had the flexibility to kind of set their rates across the entire program, the employee-only rate was far, far under market. So even if your claims had been great, which they weren't, but even if they had, no matter what, the rates were going to need to still go up to just get to where the market rates are. So one other thing that we wanted to kind of be able to illustratively show for you are kind of contribution rate scenarios. So you heard from Hannah at the very beginning that, you know, there's employee dissatisfaction, and then, you know, employees that come to work here are having a very hard time offering health benefits to their dependents, whether that's children, spouses, families, because the rates are just, you know, very, very high. And they're high across every employer, every type of market. However, you know, the way that you can help with that is by increasing the employer contribution there. And so wanted to just illustrate for you kind of a couple of different scenarios as to how that $2.3 million kind of translates. You'll see it shows it a little bit higher because we're using 196 in this chart, where that Pareto proposal was at 186. You have 196 slotted open positions here today. And so we're trying to give you a most accurate model as far as what that contribution looks like per person. And so I had mentioned earlier that we always try to recommend funding to the maximum. So you'll see in the spreadsheet, basically you have current rates in one column, and then you have 4 columns that are showing you at the maximum rate, which would be $2.5 million. Underneath that, we're showing you kind of what that employer contribution percentage is today. So you can see by tier how you all pay towards that coverage. So for employees only, the city is paying 100%. Then for the spouses, they're paying 47%. For children, paying 63%. And for family, paying about 34%. And so each of these green boxes are trying to kind of illustrate different types of ways to fund your contribution strategy. So the very first column to the right of those current rates, basically we're keeping the exact same employer contribution, but modeling that increase to cover that premium cost or the total expected contribution. So you can see down at the bottom what those rates would be if you kept the exact same employer contribution percentages. The next column over, we're showing you, well, what if we kept the employee deduction exactly the same? How does that change what the city is funding? And then the columns to the right of that are basically two different scenarios as far as changing employer contribution by different percentages to give you kind of a look as to how that would decrease employee deductions by tier as well at the bottom. You know, the goal is to really get to a point with this funding mechanism to take those savings that you're going to achieve and really help you reinvest those savings back into designing a program that is sustainable for the city and affordable for your employees.
Just so I want to make sure I'm understanding the numbers on here. So the difference between the 1.8 expected from the previous slide and the $2 million on the current rates in your first column there, is that the difference in just the employee count? I just want to make sure I'm kind of comparing
Nope.
apples to apples.
So let me just go back to the slide here. So the expected, the 1.8, is if you run pretty well and your claims aren't, you know, too hard, you may fall in that you only spend $1.8 million.
Okay.
However, the 2.3 in this scenario is funding to the maximum, that aggregate. We know you're not going to have to pay
Right.
any more than 2.3. The difference between the 2.3 and the 2.5 is your employee count. So
Well,
this 2.3 was only 186 people on the plan. This spreadsheet is showing all 196 allocated positions.
Okay.
The 1.8 is not coming into that.
Yeah, 1.8 isn't on this spreadsheet at all.
They're comparing it to the 2.3.
Yep.
And it's just an employee difference between 2.3 and 2.5 because it's maximum.
Oh, I see. Okay, I was looking at the wrong line. So what is that $2 million? Sorry, I'm on the next slide.
Yep.
The second red line, that $2 million underneath the 2.5.
Yep. Great question. So you can see that 2.5, that's going to be the total contribution to fund the plan. The 2 million is going to be what your share of that contribution is. Your employees are going to be paying the $500,000 in payroll deductions.
I see.
So we're trying to model for you what your share will be.
Okay. Okay, that makes sense. Okay. Okay, yeah, I was just having trouble making those numbers make sense.
Yep.
But I see it now.
Great. Any other questions on the spreadsheet? And again, these are just kind of illustrative rates, right? So when we finally get to the point where we have numbers, right, all of this will be updated with real numbers. This is really just trying to give you an idea of the different contribution strategies that we may kind of bring forward as recommendations.
I just have maybe a general question about that. As far as the structure of our plan right now, where basically the employees don't contribute anything, is that typical? Because in my own experience, I've seen the employee always contribute something, but the family and spouse and children rates are always much lower, I assume, because the other employees are contributing into the plan.
That's right.
So there's more money to kind
Right.
of make those numbers work.
So if you look at private employers, very few, maybe tech companies or pharmaceutical companies of all industries, offer 100% coverage to employees. Most private employers are requiring employees to cost share at that employee-only level because there's a large number of people that are enrolled, right? It's helping fund for that program. However, with public sector, most are funding that employee only at 100%. So municipalities, counties across North Carolina, most of them are funding, not at the state level, but at the local government level, they are funding that employee only at 100%.
Okay.
Very few have started to switch and they're, just starting to try to say, oh, well, you're going to have a little bit of cost share. Some of them are tying it to a wellness program. I know you all do a great wellness program here with offering some incentives. Some are saying, oh, well, if the wellness rate or a non-wellness rate, if you don't do the wellness, you're going to pay a little bit more. But, they're still pretty, they're very, very competitive. I mean, most of them are like maybe $25 contribution or $50. I don't know that I've seen even one over $100 employee contribution in North Carolina local government.
Okay. Do their rates generally kind of, as far as like, because I know that the family and the spouse contribution levels are kind of a stress point right now.
Yep.
Like, how do those other
So
employers handle that?
I would say, as an overall trend, most municipalities are struggling to get participation in their dependent tiers because most of them are funding at that employee-only level, and there's not enough money to go around to fund at
Right.
that dependent level, right? So it becomes a very heavy employee-only benefit across the state for, local governments. Most of them have very small numbers in those dependent tiers. Because it's unaffordable. Now, I will say the ones that have figured that out, if you go back and you start to look, the ones that are self-funded are the ones that are making that coverage more affordable because they are managing their costs very differently than they are really allowed to on a fully insured basis.
And
So-
still, at least with, still keeping the employee-only coverage fully covered by the employer, they're still, the savings they're realizing, they're able to lower those other tiers of coverage.
Yep.
But that's like a long year plan, right? What's the general turnaround time that those municipalities have like quote unquote figured it out? Like 2 years, 3 years?
Yeah,
years,
so
surely.
moving self-funded, that's a great question. I mean, moving self-funded is a long-term strategy, right? So if you all don't have the appetite for this level of risk, stay fully insured. Because it is going to take time, right? Just as much time as it's taken for us to get, the transition from the league to United, right? It's going to take time for all of those things to work out. That education alone doesn't happen overnight. And in a self-funded arrangement, education really is a huge component of how you're going to realize those savings. And so, you're going to see a little bit of savings year one, really mostly from the pharmacy spend, because those are going to happen really automatic without much effort at the patient level. To really start to move that needle, you've got to get that buy-in at that employee, at the patient level, and so it is going to take a little bit of time. So, most of our groups, I would say within 3 years, are starting to be like, wow, you know what, it is really performing very well. Our employees are really, engaged. They understand how to maximize the value of the program. It's all, kind of making sense. That's where they're really kind of, and you know what, they're being conservative. Most of the groups are they don't want to, just because you save, 20% year one, are you comfortable already taking that entire 20% and reinvesting it? Probably not. Maybe you take 10% and, keep 10%. So it is a multi-year strategy to really start to realize those savings, and kind of requires that commitment up front that, what, we're gonna do this for the long haul, and we're going to invest appropriately, and we're going to really from the top down send the messaging about employee engagement.
Is that, I guess, Hannah, a question for you, is that acceptable from what you're hearing on culture surveys and stuff like that from our employees? Like, this isn't going to be an instant benefit, which is how I understood from the retreat a lot of people are looking at, right?
Yeah, I think speaking, just piggybacking off Donna, it's not, even if we weren't to go to a self-funded option, it's still not going to be an instant benefit. It's speaking to the education component of it. It's going to take a lot of that for employees to help them realize the long-term benefits of this. So I don't think either way they're going to be instantly satisfied with whichever option we choose. But I don't want to say that.
A lot of that may be revealed whenever you get the renewal, right?
Well, based on the employee recommendations from the task force, number one item the very first sentence, change our insurance provider or insurance plan to better support employee well-being and retention. So that's where we've kind of had this discussion with Hub International and internally was like, all right, we've been doing the same thing for years. It's not getting any better. Today's the day that we need to make a change potentially if we see this renewal coming in from United Healthcare with a 50% increase, which is the exact same amount that we'd have to fund for self-insured program. So as Donna continues on with her conversation here in this presentation, you'll see that, you know, we're running the parallel path to see if we get, hopefully, I mean, it'd be great if United Healthcare came back with 0 to 10%. We'd probably jump all over it. That's probably not what, I mean, they've been studying our health insurance claims, and that's probably not what we're going to see. And so now we're trying to take both paths and give you as much information. If we see something different coming up in the budget process, this is the reason, because we see it coming. And this,
sure.
like she said, you know, it's like long term. We've got to, if we're in, we're in. We can't go in and out, in and out, in and out. So we think that those cost savings that we'll see will help at some point to start reducing those deductions for employees, and so we can keep that level year over year, or either a small percent increase. You know, if it's 0 to 5%, I think employees would be fine versus like 50%, and last year 22%, and the year before 9% or whatever it was. So we're trying to get that down to make it
Less volatile.
more level. Yeah,
Yeah, it's definitely, the years are gonna go by. They're gonna go by, so positioning ourselves to be able to capture the benefit, even if it is in a few years, makes a lot of sense in my mind. The big takeaway that I hear is that it allows the city to manage its investment more than a fully insured. Once the money's paid and a fully insured is gone, whether we're using it or not. But this allows that flexibility and hopefully the education and the movement and the being able to cater it in ways that save money or allow us to expand benefits to employees. So yeah, it's, again, thinking down the road as opposed to necessarily where we are right now. And I have one question, and we can jump back to that if you have more questions. But I have one question, and you may have touched on it, I may have missed it. Is there a big demand for the family coverage, or are we just abnormally low in demand?
When you break into the demographic analysis, 30 and under, yeah.
There's a big demand for it?
For me, when they come to me directly,
Yeah.
yes.
Yeah, okay, so when we say, look, we've only got like, 2 people that are on family coverage or whatever it is.
Yeah, I can speak directly to those. We implemented a new benefit, maternity and paternity leave, 6 weeks. With our last updates to our policy, that was in March of last year. Since March of last year, I've had probably 7 employees take advantage of that. I think only 1 put dependents on their coverage. The others, I had to help them outsource to the marketplace and provide them resources to the marketplace because they couldn't afford our coverage.
When you say
And
the
I think that's why you're not
marketplace,
getting-
you mean like Obamacare?
Yeah. I think that's why you're not getting the participation. If
Yeah,
there's
yeah,
other
that's
tiers,
what
the
I was getting
affordability.
at. So that, in my mind, you know, when I'm thinking of these on the slide before this one, you know, which one are we looking at? That would be the driving factor
Yeah.
to be looking at the ones that were reducing that family.
It's probably not due to lack of interest. It's
Yeah, that's
all
what I was-
about the
that's what I was
affordability
wondering.
Well,
of
how
it.
much of that is like, because it's like a cliff, right? Because you go from 0, and then
Yeah.
if you have a family,
$530.
$500. I don't know, like what would be considered, do we have a feel for like what the employees are looking for as far as affordability on that?
Directly from the employees, I've not gotten specifically, hey, this is what I can afford. I just get, I can't afford this.
Yeah.
Yeah.
What you're offering, I cannot afford for my family.
Because
any
how
of-
much of a percentage of their, like, annual salary is, according to
Yeah.
materials, it's like somewhere
Yeah.
close to 30% potentially?
So for people who have employee child, I think we calculated it was roughly about 6% of their salary. But when you go up to, I think it was about 15% when you include spouse, and between 15 and 30 for family, depending on the salary of the employee.
Yeah, so Hannah ran some numbers in a spreadsheet, and we have like 42 employees that have the benefit election of employee, spouse, child, family coverage. And then their percentage of the gross income, I mean, it ranges, and the lowest, of course, you know, the lowest paid employees, that would be a higher percent. So we're up to, I think the highest one in the spreadsheet was like 30% of their take-home pay was going, 30.54% was a family employee and this employee was one of the lower paid employees, so 30% of that pay is going towards our health insurance. On average, though, for all those 42 employees, it's 7.81% of their gross income goes towards the payments. So you've got a range, highest 30, lowest, maybe the highest, some of the higher paid employees, it could drop down to like 2%.
Have we looked at tiering the rates?
That's what I was just about to say.
So like, you know, you make, I'm just making up numbers. You make less than $50,000, the rate's X. You make less than $75,000, the rate's X plus 10% or whatever.
At present, no, we haven't looked at that option.
Is that an option we can look at? Because you almost will need to subsidize to a point for folks who are making a lot more versus folks
Yeah.
who are on the lower end of the spectrum here, where you're just gonna apply the total leverage cost of the insurance policy across everyone, right?
So that is definitely a model that has become widely popular in private sector. And if you know, the state health plan actually here in North Carolina just moved to that model this last year, tiering by salary. So, you know, that is certainly something that we can take back and model for you all as well, and work with Hannah as far as which categories of salaries do you think need to be kind of put together? You know, I mean, you don't have to make it complex. You can do 3 salary bands. You could do 5 salary bands, right? You can kind of design that however you'd like in this type of an arrangement.
The wellness rates kind of intrigue me too, because like that also kind of helps align incentives between the employees and the plan.
Yeah.
You know, you get rewarded with lower rates if you're doing stuff that saves the plan money,
Yep.
which then benefits everybody on the plan. Just thinking out loud here, but I like that
Could-
idea too.
Because that's where my head was going when I was looking at some of this stuff, particularly the total dollar value. But, you know, maybe what would be nice to see additionally for the conversation is, I know we're looking high level to say, what is the city going to invest in for this insurance policy? What is the budget going to be going forward? But why don't we have the information of the bottom tier and see what that percentage is? Because that's almost what we need. It's 2 equations. How do we make it affordable for people who can't afford it today, who work for the city? And how do we maintain and be good stewards to the taxpayers of the total value? And I think we can play around with a model. If, Miles, you've got a spreadsheet there, whatever the buckets are, 30% goes to 10%. You know what I mean? But this is what it does to the top level of what we have to pay as a total city for the insurance, but then this also does for the top people who are being paid. Like, that's almost what you have to do here, or we're never going to solve the problem.
Yes. Yep, so we can certainly model that with those.
Does that make
Numbers.
sense to y'all?
Yeah, yeah. And I think from like an employee recruitment attractiveness perspective too, you know, if we can figure out a way to crack that nut basically to make those sort of non-employee rates more attractive, that would help with some of the retention aspects of this too. Because like, I mean, it sounds like a lot of other places are having a similar problem, which maybe means that it's a, you know, intractable issue. You know, who knows? But you know, there's a lot of smart people here, so.
And I think the only thing else we need to add is what is like the market benchmark? Because like, we have to keep in mind that 100% of the employee cost is being covered by the city. So we have to think of it as, what if it wasn't that way almost, and what is the total cost? Does that make sense? Like, what is the market benchmark that we should be targeting to? Because for me, in my mind, I'm like, I pay for insurance in the private world, right? And then there's an additional coverage for my family. My company doesn't pay me 100%, but what would the offset be if that was split? Like, what if they did 100% cover me? What would that mean for me?
Yeah.
Like, there's got to be a percent or benchmark on gross pay that meets like market
Well, the other-
acceptability.
And the other thing too is like, if you can make the family and spouse coverage more attractive, which are the higher rates, you'll have more people enroll in those coverages, which theoretically brings more money into the plan.
Correct.
So like, the employee rates at that point become less important because they're not paying them anyway.
And then it accelerates your savings
Yeah.
plan for,
Yeah.
You touched on, I think, at least one of the nuances earlier between, say, public and private sector when it comes to health insurance pricing. Are there any real significant differences typically in like plan design or pricing when it comes to public versus private sector that you see?
Plan designs are pretty much the same, across the board as far as, what's the copay, what's the ER visit, those kinds of things. Pretty much across the board. I would think the type of plan designs though that are being offered certainly have changed. So, high deductible health plans is really in the private sector. That's the go-to, everybody has it. Some only have high deductible health plans that either are paired with a HSA or an HRA. They no longer have that traditional copay structure. It's, really first dollar for the employees, and maybe they fund some particular amount of money into that HSA or HRA account for the employees. So, but, as far as the types of plan designs, I would say that's pretty consistent. Mm-hmm. It's just really whether they offer a traditional copay plan or high deductible plan.
Well, I like some of the positive aspects you've touched on this evening with the self-funded route. I know that's really, with large employers and certain municipalities, that's kind of the direction a lot of them go. I like the transparency, the ability to better control, and kind of, especially on a go-forward basis, because to an extent, how long we're going to keep kicking the can, and just digesting these 10, 20, 30% increases every year. And, those numbers, that spread between family coverage and employees is definitely not going to get any better under that scenario. So if we're really looking to make things more affordable, I'm intrigued by your option, maybe looking at a tiered approach based on compensation perhaps, if that's something that's an alternative to look at. But I know that self-insured is do you see that in terms of the public sector? Is that with municipalities, say, of our size, that is more the norm nowadays?
So groups that have been introduced to captive arrangements are moving in this model. So, and we expect to see more and more of them moving. We're seeing more and more smaller employers smaller than you moving into this model because they are tired of kind of that rat race. Because today the only recourse that you have when I come with that renewal and say, oh, United wants 30, 40, 50% more, the only recourse we have is, well, let's increase that deductible. Well, let's increase those copays, right? We don't have those conversations with our self-funded clients. You pick a plan design, we run that plan design, right? Because we have levers to move that are going to mitigate the cost. We don't have to worry about, oh, let's increase that deductible by another $500 or $1,000, or let's increase your copay from $25 to $50. You choose a plan design, and we run that plan design. And so, that just gives a lot of freedom to you all and really to your employees from a stability standpoint that, hey, you know what, we do have great benefits here at the City of Belmont. I've had the same copay for X number of years, right? And they don't have to be having those same conversations that unfortunately every other fully insured employer is going to have and has been having. The problem is there are some employers out there, they've run out of options, right? They're already at the top of the copay structure. They're already at the top of that deductible structure. They have no more recourse in that fully insured arrangement. So as Miles mentioned, as far as what next steps look like, we've kind of laid out a timeline here. We do expect the United Healthcare renewal to be released in April. At the same time, we are going to be negotiating that renewal and doing a complete market survey. So just because Blue Cross and Cigna and Aetna said no last year, we're going to go and ask them again this year what they want to do. We don't necessarily expect different results, but we want to definitely do a market check to make sure. And then we're also working at the same time on formalizing a strong stop-loss proposal through Pareto Health. So that way we can come to the table with you all to all of the options to the city leadership by early May that says, here are all the options that are available in the marketplace for you all to consider, fully insured or self-funded. With the hopes that by late May we would be in a position to share the news with whatever the city decided and conduct open enrollment. And that's really where the work begins, as far as, you know, really making sure that the investments that you're making in your plan will hopefully prosper with employee engagement and communication under that self-funded model. You know, the thing is, under fully insured, right, you want to do it, and you guys have a great little wellness program and, you know, trying to incentivize good behavior, but you don't reap the benefit of it today. So even if every single person on your plan was like, oh, I'm going to do all of this great wellness stuff, you're still going to get a rate increase from your fully insured carrier. If they do all of those things in a self-funded arrangement, right, your money isn't going out the door. And so, you know, that's really the big difference between kind of the model that you have today and, you know, kind of if you decide to move into a self-funded arrangement.
So like in this move though, I guess maybe a little bit more on the granular level, is the benefits as it pertains to the provider and level of care the same, better, or worse?
So anytime you change networks, there will be differences. And anyone who tells you there will be no differences is lying, right? Because every single provider contract is different with every carrier. So we leave United Healthcare, say we move to MedCost or Aetna. The contracted rates are going to be different for those doctors than they are today with United. If you have a copay, not going to make a big difference. But let's say you have a surgery. Maybe they had that same surgery a year ago. They're going to pay a different fee under this plan that's going to go to their deductible and coinsurance than they would have under the plan that they have today. But are the benefits the same? Yes, it's still going to be deductible coinsurance. But the payment might be different based on that contract.
And then as it pertains to employees, let's say, who are paying out of pocket in those situations today versus moving into this, I mean, would that change, or the expectation of that level to change, or do you think that would be about the same?
So they're going to still have a cap, and I don't remember, what is your total out of pocket today? So $3,500 is your total out of pocket spend. So no matter what, your employees are going to spend $3,500. But it might be different if they spend it, you know, at different increments. Those charges might be a little bit different. So, oh, the x-ray that I had at this provider down the street was $50, but now I went to that same provider and now that x-ray was $45, right? But at the end of the day, in the course of the plan year, they're still only going to pay $3,500 total.
So the $3,500 is what we're expecting for the new plan as well, potentially, right? It's the cap.
And
Or
if
is that-
self-funded,
It was modeled
we're
the same.
we're modeling, assuming you're going to keep your same exact plan design.
All right.
Okay, let me ask you this. So I hear lots of things that I like. So what are the downsides to this self-funded plan? I mean, in my mind, I'm thinking, well, if we have all these good things, why would everybody just not do this? Why would there be these fully funded or whatever we're on now, like the jargon for that? What's the downside to us moving this direction, other than just more administration?
More exposure. More exposure.
Well, we have
So-
the cap. I mean, we have the insurance.
If you build
that
your
would cover the
program
cap.
right, we don't see a downside, which is why most of our groups are moving to this arrangement. There is a little bit more administration. So,
Okay.
you know, as far as what Jared and his team are going to have to do, right, the reporting is going to be a little bit different, right? We're going to have to set up some banking calls. We're going to have to
Jared
set
likes
up
a
the
challenge.
structure. You're going to be a little bit of things on the front end that you have to set up differently, right? There's going to be different reports that come in, you know, on a weekly basis. There's going to be a request that says, Jared, we want you to authorize $150,000 to pay for claims, right? Next week it might say, well, we want you to authorize $25,000 to pay for claims. When the stop loss gets involved, so you have that claimant, high cost cancer claimant, 900,000, right? When the stop loss is hit, anything over, say, that 75, there's going to be a flag that comes back to the city of Belmont and says, can you verify that this person is actually on your plan? You know, this is going to go through stop loss. So there's going to be a few extra touch points in a self-funded arrangement that don't exist today.
How does COBRA work with a self-funded plan?
The exact same as if you're fully insured.
Okay.
Going back to your last point, what does our capacity look like from a staffing perspective on that?
From a staffing perspective, you're talking about with Hannah and
Well, like I
Jared's
know,
staff?
like for example, Jared's already very busy.
Yeah.
I'm sure that having to now deal with stuff like this is going to be more on his plate. Like, does he have room on his plate to do that, or do we need to start talking about headcount for stuff like that?
I think for the the good part is we have Hub International, first of all, that kind of helps us go through this process. Since we're kind of unbundling all of that and we have different contracts, I think that they kind of help us set that up. So it's good that we have a broker. If we didn't have a broker, I'd say we probably needed multiple more employees to do this, because we wouldn't know. So to have the professionalism of Hub International, I think that helps us out. I hadn't really studied, do we need another employee to help us out with that? So I don't have an answer quite on that. I think that we could rely on our vendor to help us out through the process.
So the third-party administrator is taking the bulk of that's happening kind of at the high level, and they're just coming to the city and saying, hey, this is your expense, essentially, your spend for the month, and it's just more of an expense line item that's being paid out, right?
Yeah.
And
So it's
sorry.
all electronic, everything's available, electronically, and so it's pretty much a click of a button. Yes,
Okay.
you're allowed to take the money out. And I mean, you set the parameters, so maybe he sets a threshold. You know what, you have authorization to pull this much money. I don't want to know. You can just go ahead and pull it without asking, So when we set it up at the beginning, you'll set the parameters that you all are comfortable with.
Okay.
I think going back to one of your questions, Mayor, about what's the downsize to do this? I think for this first year, there's a cost difference, because last year our premium, we paid like $1.6 million total. This year, we're gonna have to fund for the full 2.3, and so we've got to look at our budget to say, all right, where do we move the money from? How do we fund it? How do we set this up, given that we're in the process of balancing a budget and then have to add $500,000 more dollars into the general fund, approximately $200,000 in the water sewer, and maybe $10,000 to the stormwater. So as we're going through the budget process and balancing it, that's the complicated matter right now for us, is how do we fund it? Where are we gonna put the line item, and what is it gonna affect as the overall budget? So that's really the thing for us. Even though United Healthcare would be doing the same thing if we get the 50% renewal.
Right. Okay.
But it's just for this first year, until we start realizing the cost savings to get us back down every year. The first year is the most troublesome for the budget.
That's a good point.
On the analytics side, how much of that do you assist with, and then how much of that kind of falls on us? And then as far as what you've seen, what's the best setup to take advantage of? You're just saying we'll have access to all the claims data and everything else, which is great if we know what to do with it, but.
Yeah, so we don't expect you to know what to do with it. We're not going to ask you all to have to know what to do with it, right? So that's what we do, right? Our entire team, we have a whole team of people, that really monitor those claims, and kind of share those ideas. These are things that we're seeing. Here's some things we could be doing differently. Do you want to do these now? Do you want to wait until renewal? Right? So those would be continuous conversations that we would have with you all. We don't expect anybody here at the city to have to log in to look at those claims, right? Our team can do that. You have access, but I would say even in the private sector, employers are not digging into their claims. That's what they have brokers for, and that's our job. And the benefit of Hub International is we not only have our own actuaries and underwriters, we have our own clinicians, which is very non-standard in our industry. So anytime we see anything that all of a sudden flags, we have our own clinicians and our own pharmacists where we can go back and say, hey, what is this? Why is this happening this way? Is this an error, or is this something that would be normal in this treatment? And then most importantly, they're able to say, hey, but if we could do this. So, here's a scenario of one thing that we found in one client's claims recently. When you receive infusion treatments, they're billed under what's called the J code. They're done at a facility. So you go into a facility and you receive an intravenous, and that drug is dispensed into that person. We saw the exact same drug dispensed at 2 different locations with an $8,500 spread in pricing. Wow, what should we do about this, right? So we're not going to do anything about it, but what we are going to do, and we have done, is go back to the employer and say, okay, the exact same medication was, intravenously applied to 2 different people at 2 different facilities, and there's this swing of $8,500. Would you like to create a steerage where people have to go through this mechanism to get that rather than this scenario. So things like that, that's just one little example that, just came up here recently that we were like, oh, okay, well, that's worth a conversation. That's what proactive plan management looks like, where today, we have zero control over that. I mean, because we don't even have exposure. I don't even know that J code existed in your plan today, right? So things like that. If we start to see trends in certain types of conditions, is there something that we could put in place to help steer that? So, another MSK, so musculoskeletal injuries, right? So all of your guys that are out there, doing manual labor, right? I'm sure you got a lot of back issues, those kinds of things, knees, hips, right? Well, there's a new solution that basically is using stem cell therapy to recure that part of the body without that person having to go through surgery. It's a zero cost solution to build into a self-funded plan. You got to tweak your contract language a little bit so that their fee schedule can be allocated at the TPA. The employee doesn't have to go through surgery. You don't have to have them out of work for 6 or 8 or 12 weeks because they've had surgery, and they do a little bit of physical therapy and have that treatment done, much, much less invasive.
But is that something that on a fully insured plan would even be covered?
No,
That type of
it's not
treatment?
even going to be, no, they're not.
But you would have that option, for
Yeah.
instance, under a self-funded
Yeah.
plan, you have that kind of latitude.
That's right. Yeah, because you're basically doing a direct contract with those providers that specialize in that treatment, and you're agreeing to their fee schedule,
Yeah.
which is a heck of a lot less than paying for the surgery for those
Sure.
people.
Well, that's becoming a lot more mainstream. Yeah.
Yep, yep. So things like that are just examples that, we work with our clinicians, we work with our health and performance team to, monitor what's happening, but come to you with suggestions as far as this is considerations that you may want to deploy to, the benefit of the plan.
Excellent.
Thank you so much for all of your time. You all have been very gracious with me taking so much of it here this evening, and really appreciate the discussion. So
Thank you, Donnie.
you.
You did a great
Excellent.
job
Thank you.
explaining a very complicated
Thank you very much.
subject and fielding questions. We really appreciate your time.
great, you're very welcome.
Any further discussion on that? I think there were a lot of good questions, a lot of information that came out. It is a heavy lift to understand all of this at the moment, especially for me. But it sounds like there's a lot of good people working behind the scenes to get us the right information so that we'll be able to make those decisions. I can say personally, my initial takeoff of it is that I like the, Jason, as you were saying, kind of the flexibility or the latitude for the city to be able to control a lot of what's happening there. I love the idea of the money, not necessarily just going out the door and going into the ether, but that for the control to be a little better. I think that makes a lot more sense in my mind. But definitely something that we'll want to dig more into. I'll be interested to see what the renewal comes back. I fully expect it will be at the top end of the assumed.
Well, especially when they
number.
don't have much of any competition. it
Yeah.
sounds like.
Well,
Yeah.
I mean, our
You know?
claims history isn't exactly favorable
Right.
either, so.
But if there's only one player, I mean, how much leverage do we have?
Right.
Yeah, yeah.
A lot. Thank you, Hannah, also for putting the time in to get that together, and Miles for working with them to do that. Is there any other questions on this? So this is our only agenda item this evening, so if there's no further discussion on it, I'll entertain a motion to adjourn.
Motion to adjourn.
Motion to adjourn by Alex.
Second.
Second by Jason. All in favor?
Aye.
Any opposed? All right, we'll stand adjourned.